One. Good afternoon. I am Kelly Harley, and I'm the former Public Information Officer for the Chatham Emergency Management Agency. And today I am joined by Dr. Lawton Davis, who is the Health Director for the Coastal Health District, which serves 8 counties here in Southeast Georgia. Welcome, Dr. Davis. Thank you for joining me this afternoon. Hot topic we wanted to talk about is the rollout of the COVID-19 vaccine. We know it's been the topic of conversations lately around here in the state and in the country as well. I know Georgia's first vaccination phase involved vaccinating those healthcare workers and residents and staff in the long-term care facilities, and that phase was then expanded to include those 65 and older. We all know that things were a little bit rocky at the beginning, not just here, but also around the state. Can you kind of give us an update as to where things stand today?
Sure. As you stated, our target population initially was healthcare providers who were not associated or affiliated with one of the major healthcare systems, the hospitals, throughout our district. And we always assumed that the healthcare systems would take care of their own employees, which they've done. We had an online enrollment process, and that actually was working very, very well. There was also, the hospital systems actually didn't have enough vaccine to get started early on. And so we shared some of our initial allotment of vaccine with them to let them jumpstart their process. So that was doing pretty well. And then phase 1A plus got here just a little more quickly than we had anticipated. And I will say that the interest in those who are over the age of 65 in receiving the vaccine has been very refreshing and very overwhelming. And so, yes, we were our telephone system was overwhelmed. We did not have an online registration system for them. And so, yeah, it got a little busy.
And would you say, that backlog, is it, was it a matter of not having enough staff or not enough vaccine, or a combination of both of those?
I think it's a combination of both. We've always known that public health itself does not have either the brick and mortar structure or the personnel to vaccinate everyone in that category. And so what we've counted on is having other healthcare providers enrolled to be vaccine, providers as well. Quite a few have enrolled and are certified providers, but early on, again, they were not able to get an allotment of the vaccine. And again, our strategy was to share what we were able to get with as many of those who were willing to vaccinate, the general population. And that's actually gone pretty well, and we're working through the backlog, and several large providers in Chatham County have now come online and are vaccinating their patient populations, and that has helped tremendously.
Okay, and that, kind of leads to another question. Will there be enough vaccine for people to get their second doses?
Yeah, that's the $64 question, and so far the answer is yes. We are scheduling second appointments for people when they receive their first dose from us, and thus far we have been able to receive enough vaccine each week to cover us for the coming week, what we know we can administer. We're not getting excess vaccine, but we're not running short either. So we anticipate that will continue.
Okay. And in terms of, vaccinating people, I know my husband, he's law enforcement, so he was able to get his vaccine today. It was pre-scheduled. But when it comes to, to vaccinating the public, would it be easy to schedule kind of like a drive-through event like you would do for the flu vaccine, or even something that was done for COVID testing?
The short answer is sure, you can do that, and we know it's feasible because some places are doing that, some of the larger communities. There are also some potential problems with that. These vaccines are not nearly as easy to handle as the flu vaccine. They have rigid temperature, storage requirements, and plus we have to watch each person for at least 15 minutes, some of them 30 minutes after they receive a dose of the vaccine. So you not only have to be able to have people queue up to come through the line, but you've got to have a place for all those cars to go and be somewhat separated and watched and monitored, so that if somebody does have a problem, the emergency personnel the emergency responders can get to them quickly.
And that makes sense. Okay, and as for the vaccination rollout, the healthcare workers, and the age 65 and older, in terms of people with underlying medical conditions, is there a reason why those folks were not at the top of the list in terms of being vaccinated?
Well, in Georgia, we have attempted to follow fairly closely the recommendations of the ACIP and CDC. The expansion into everyone over 65 was a little bit of an early departure from that, but again, we're trying to pretty much follow the guidelines that have been established.
And then, once those people with those underlying health conditions can get vaccinated, will they need like a note from their healthcare provider, in order to get that vaccination? And how will it be determined if they're eligible to get the vaccination?
That's a very good question, and also a very tough question to give a succinct answer to. We out here in the field have communicated that we really need clear guidelines. We need before we get to that phase, we need to have the criteria set so we'll know exactly what we're going to do. Discussions are being held now at high levels to determine those criteria. I personally would doubt that we would have to have a note from a healthcare provider, but again, stay tuned. I don't have the final answer on that yet.
Okay. You don't have a crystal ball. As far as people, wanting to get the vaccine, they're anxious. My mom being one of them, 65, well, she's in Effingham County, a different county. A lot of my teacher friends, they're anxious to get the vaccine. Any idea when, we'll be moving into that next phase for, let's say, teachers?
I'm really not sure. We're guessing that there are roughly 50,000 people in the expanded Group 1A plus that we're working on right now, just in Chatham County, and probably 100,000 throughout our district. That's a lot of vaccinations. And so if we stay with the current phase until we complete it, it'll be a little while. Now, will the timeline be moved up somewhat like it was with the 1A plus expansion that took place, last Monday? If that happens, I suspect we'll once again have more people eager to be vaccinated than we can readily handle. So as soon as we have a little advance warning that it's coming, we'll certainly let people know. But again, you just mentioned I don't have a crystal ball, so I'm actually hoping we stay with 1A plus until we make a bigger dent in it than we've been able to do so far.
Okay, and kind of shifting gears now when it comes to children. Will children be able to get vaccinated? And kind of a two-part question, not only children, but the children with underlying medical conditions.
At the moment, neither of the vaccines that we have available, Pfizer or Moderna, are approved for children. Pfizer can be given to people age 16 and over, and Moderna to those age 18 and over. The all-knowing they that do these studies are working to recruit children to be vaccinated. They have to determine the safety and efficacy, just like they did before, those like me who are over 65 could be vaccinated. So those studies are ongoing, but we're just not there yet.
Okay. And then, as for the vaccine itself, we know that right now it's requirement for the 2 doses. Is it absolutely necessary to have both of those doses?
Well, there's a short answer and a long answer. And the short answer is no, but we really want you to. If you look at all of the studies of efficacy, they were based on a 2-dose regimen. However, we do know that there is leeway on the backside. You don't want to take the 2nd dose too early, but if something happens, for some reason you can't keep an appointment, or there's a temporary shortage in vaccine and your 2nd dose of Pfizer gets pushed out to day 30 or day 35, that's fine. It'll still work. So we encourage people we're making 2nd dose appointments as close to the correct time as we can. We encourage people to keep those. But again, if something were to happen such that you had to miss the date and come back, a week or 2 or 3 later, that would be okay.
And can you kind of expand on that? You touched briefly on the time frame, but maybe a little bit more detail about the time frame between the 1st dose and the 2nd dose.
Sure. The Pfizer product is based, the studies were based on receiving dose 1 today and the second dose on day 21, so 3 weeks later. The Moderna vaccine, which is actually very similar to the Pfizer vaccine and works the same way, is dose on day 1 and then a second dose 28 days later. So 3 weeks or 4 weeks, depending on which one you get. And there are no studies yet that document that you could, even though they're closely related vaccines, we still don't recommend at all switching. If you start with Pfizer, stay with Pfizer. If you start with Moderna, stay with Moderna. The efficacy is the same. The safety is the same. So, and eventually we may learn that it doesn't matter which one you get, but we can't say that at the moment.
That makes sense. Okay, moving on. With a lot of positive cases, if someone has tested positive for COVID-19 in the past, what is your recommendation on them getting vaccinated? Should they still get vaccinated?
Yes, they should. It actually appears that the vaccination may provide a more robust immune response and possibly a longer lasting response than actual infection with the virus. So if you had COVID-19 2 weeks ago and you're completely recovered, yes, be vaccinated. The caveat there is if you received convalescent serum or plasma, or you received one of those monoclonal antibody therapies, then we ask you to wait 3 months before you're vaccinated.
Oh, wow. Okay. And then a question to that, what if you test positive a few days after getting your vaccination? Like, is there a time period you should wait before you get your second dose that goes outside of those guidelines currently set?
Sure. And actually that has happened a time or two. And I'd first like to reiterate that the COVID-19 was not caused by the virus. The vaccine, the COVID-19 disease was not caused by the vaccine. It was caused because that person had previously contracted the virus. And we'll come back to that in a minute. So if you are vaccinated today and your test develops symptoms and you test positive in 4 or 5 days, what we ask you to do is to complete your period of isolation, which would be either 10 days or 21 days, depending on how sick you were. But assuming you are like most people and you recovered by the 5th or 6th or 7th day and you've been afebrile, then after you have recovered, and assuming you're not treated with one of those things I just mentioned, convalescent serum or a monoclonal antibody, then you can have the second dose.
And so basically, testing positive during the vaccination process doesn't really change the outcome of the vaccine. Okay.
Only if you are treated with one of those 2 modalities.
Okay. And then, exactly how does the vaccine work? We know that it's an open question, but it's different than other vaccines out there, obviously.
Yes, I'll try to put it in layman's terms. We're kind of all familiar with computer coding, and you put a program into the computer and it does what you tell it to do. These vaccines use something called messenger RNA. If you think back to high school or college, you studied DNA and RNA. And messenger RNA this little piece of messenger RNA is made in the laboratory. It's not taken from the virus itself. So it's a little manufactured bit of genetic computer code. It's attached to a little tiny globule of fat, which is suspended in salt water. It goes in your arm. Your immune system recognizes those little globules of fat as being foreign, and so it picks them up just like it's supposed to do. The messenger RNA is released into the cytoplasm of the cell. Remember, you've got cytoplasm, and then you've got, think of an egg, the yolk is the nucleus, and then you've got the cytoplasm out here. So the messenger RNA does not go into the nucleus of the cell, but it does act like that computer code, and it turns on the protein manufacturing capability of that cell. And it actually causes the cell to manufacture a little bit of that spike protein. If you think of the cartoon pictures you've seen of the virus, it looks sort of like a World War II mine, floating around in the ocean with little spiky things all over it. Well, that's the spike protein, and we actually induce your immune system to make that. The rest of your immune system recognizes that and says, that's not normal, let's go get it. And so it does, and it creates what we call blocking antibodies. And so later, if you're exposed to the real virus, your immune system is going to recognize those spike proteins and is going to release those blocking antibodies, which will attach and prevent the virus from entering your cells and going inside and doing the dastardly deeds that it likes to do.
And so, and explain too, the vaccine, it does not include the virus at all,
No,
correct?
there is no piece of the virus in the vaccine. The vaccine does not have eggs, it doesn't have preservative, and it has no component of the actual virus itself, so it absolutely cannot cause the disease.
Okay. Now, as for, concerns, so, on Facebook, I scroll through and, there's, are you going to get the vaccine? Yes, no, heck no, this is why, and there's a lot of concerns about it, and some of the concerns evolve around, how fast it was produced. Can you address those concerns to people who may say, I'm not interested in the vaccine because it was produced so quickly and I don't trust it, and
Sure.
so forth?
Yeah, typically vaccines take years to develop. The technology used to make these two vaccines that we currently have is not new technology, but it's the first time it's been used to make a vaccine. Again, they manufacture the genetic coding messenger RNA in the laboratory. They attach it to fat and they suspend it, in salt water. So it's a very clean vaccine. It doesn't rely on culturing another virus and then inactivating it. It doesn't rely on injecting it into eggs and letting it incubate in eggs like some of the flu vaccines are done. And so it's a purely laboratory process, which is distinct from the other vaccines that we have out there. The other thing to remember is that the federal government passed several regulations that allowed companies to cooperate, what we would ordinarily call collusion probably, and they could share data and work together. And also the shortcuts that were taken were on the bureaucratic side of things, not on the safety and efficacy. So they did the requisite number of people, studied the actual vaccine as far as safety and efficacy, but they cut out a lot of the bureaucracy that typically goes on in the background trying to get something ready to come to market.
Okay, and that makes sense. Now, you and I, we're sitting here, we'd say roughly 6 feet apart. We don't have a tape measure, but I would say so. You've been vaccinated, I've not been vaccinated. As far as people who have been vaccinated, do you still recommend them taking the same safety precautions that they are now with the social distancing, the mask wearing? And if so, why is that?
Another great question, and it is a source of misinformation out there. The studies done on the vaccine were designed to determine how effective the vaccines are in preventing clinical symptomatic illness. In other words, preventing you from getting sick. They were not designed to detect whether or not you had an asymptomatic infection, or you could call it colonization with the virus. We know that somewhere between 35 and 50% of people are asymptomatic, anyway. And so the studies did not determine whether the vaccine would prevent me, even though I probably won't get sick if I'm exposed to it and contract it. Will it prevent me from actually developing a silent or an asymptomatic infection and still being able to spread it to others? We don't know the answer to that yet. So in response to your question, yes, when you're vaccinated, you're still supposed to wear your mask, watch your distance, wash your hands, avoid crowds. And if I know that I'm exposed, if tomorrow it turns out that you actually have it and I've been sitting here talking to you, then I should still quarantine.
Okay.
Because we don't know whether I can develop that asymptomatic infection and unwittingly spread it to somebody else.
And do you think there'll be a point in time where that will be known?
Oh, yes. And there are a lot of people who feel that the vaccines are so effective in preventing clinical illness that they probably prevent asymptomatic or silent infection as well.
Okay.
But until we know for sure, we don't want to take a chance.
And that makes perfect sense. Okay, I know we talked a lot about the vaccine today. Can we touch base on the variant strain that we're hearing a lot about, and kind of what that means, to us here, not only in, the United States, but also here in coastal Georgia?
Well, yes, there are actually several variants out there. Viruses typically mutate all the time. That's one reason you have to take a new flu shot every year, is because the flu viruses change. The coronavirus is not much different. It's going to change. But this particular strain, B117, as I think they're calling it, seems to have changed enough that it has become much more contagious than, say, the original, COVID-19 virus, SARS-CoV-2. It seems to live more predominantly in the upper airway. It allows a greater volume of the virus to grow in the back of your nose and your throat. And so I suppose that you're potentially exhaling more of the virus, each time you cough or talk loudly. And it is much more infective, probably at least 1.5 times as contagious as the other. That's the bad news. The good news is that so far it does not seem to cause an illness that is more severe than what we originally had. And also the vaccine that we have still appears to be effective. We know that I'm not aware of any documented cases of B117 in the Coastal Health District yet, but we know it's in Georgia and we know it's everywhere else. And a lot of people say it's going to quickly become the predominant strain. So if it's not already here, it will be here. Let me go back to the vaccine for a moment. It could be conceivable that the virus could mutate enough that, the spike protein may change enough that our current vaccine doesn't work. I mean, we don't know what this virus is going to do. But the technology used would allow them to go back and create a different piece of messenger RNA and use the same process they used to put the vaccine together and roll out another one, pretty quickly, and without having to culture it in eggs for 6 or 8 months and all that sort of stuff. So the technology is really slick and great, and I'm very impressed with it.
It sounds very encouraging.
Yes.
During this time. So we've covered a lot today, 2 pages, really full of questions. Is there anything else that you would like, the public to hear, anything you want to touch on that we may not have specifically talked about?
Well, I mentioned that we're still, the virus is changing. We're still learning about this virus. Everybody needs to remember that a year ago, in fact, I think a year ago today was when officially the first case was diagnosed in the US of A. So there's just a lot we don't know. The virus is going to determine a lot of, how we go forward in the future. We don't have control over that. We're still learning about how long natural immunity will last. We don't know for sure how long the immunity is going to last from the vaccine. I've read that Moderna is actually beginning a study to give a booster dose, after a year in a pilot group to see if that's beneficial or helps. And in order to come out from under this cloud, we really need to develop what is known as herd immunity, and that's, a herd of cows, not like I heard it through the grapevine. We need, and they kick around different numbers, but at least 70%, probably 80% with this new strain, maybe 85% of people need to be immune to the virus in order for it to go away and leave us alone and let us to get back to some semblance of normalcy. The only ways to do that are either to have the illness and recover and hope that we develop a long-lasting immune response, or to be vaccinated. So we really need people to step up and take the vaccine. The more people that have the disease, the more people we lose, and we've already lost too many. So we really need people to step up and be vaccinated. And then the point that you brought up, being vaccinated, I'm not surrounded by an invisible force field such that I can't become infected. We don't know the answer to that. I still wear my mask. I still won't go into a restaurant and eat. I'm still not going to church inside. And until we know some more answers, I won't be as much to protect others, as to protect myself, because I could unwittingly become colonized or have an asymptomatic infection and give it to you.
All right, well, thank you, Dr. Davis, for your honesty. I know we covered a lot today. I know, there's a lot of questions probably people will still want answers to. Thank you for your hard work. I know we talked briefly before we started this, and I asked you if you get any downtime, and you said some, but I know you're working, very hard, and your team behind the scenes is working very hard too. And this is learning for everyone. So thank you again, and thank you guys for joining us. And if you have any other questions, feel free to reach out to the Coastal Health District via their Facebook page or their website to help answer some of those questions that you might want some answers to. Thank you. Thank you, Dr. Davis.
Thank you.